Hello and welcome everyone. Today's presentation is on angiotensin II and how to use it in our practice. Now, an overview of this. Angiotensin II is a vasoconstrictive peptide involved in the renin angiotensin aldosterone or the RAS system, crucial for maintaining the blood pressure and fluid homeostasis. It is potential as a vasopressor drug in the ICU for treating vasodilatory hypotension, and shock is already established in a large trial in NEJ. Now, the historical use and its discovery. Despite its long history of safe use in human studies, angiotensin II wasn't commercially available until very recently. Now, in 2009, it was shown in gram-negative septic sheep that angiotensin II infusion improved the renal function, sparkling renewed interest and leading to commercial development of the brand name Giapreza. Now, the most important trial, that is the NEJM trial, that is Ethos III. It was an international multicentric double-blind RCT. Its goal was to demonstrate the angiotensin II's efficacy in increasing the mean arterial pressure in patients with catecholamine refractory vasodilatory shock. The criteria for inclusion was patient receiving more than 0.2 micrograms per kg per minute of noradrenaline equivalent. Outcome was angiotensin II aimed to increase the MAP by 10 or to more than 75 within 3 hours without increasing the background vasopressor requirement. Now, 163 patients were treated with angiotensin II and 158 with placebo. Most of them had septic shock. Angiotensin II treated patients had 8 times the odds of receiving the MAT targets compared to the placebo. So there was 70% success in the angiotensin II group compared to 23% in the placebo. So FDA approved angiotensin II as a second-line vasopressor for catecholamine refractory vasodilatory shock. Post-trial development. In US, it has been used in thousands of patients as of now. Europe has approved the same drug for the same indication as it has been for the US. In the COVID-19 trial, hypertensive COVID-19 patients and cardiac surgery patients have been treated with this particular drug. Regarding the commercial availability, it was already available in the United States and recently it has been made available in the Europe also. So the subgroup analysis of the Ethos III trial. In the renal replacement therapy patients, patients receiving renal replacement therapy at the time of randomization experienced better outcomes with angiotensin II. Key improvements included higher rates of recovery to RRT independence by day 7 and improved survival rates. Now, patients with Ang1 and Ang2 ratio below the median demonstrated a significantly higher likelihood of survival compared to the ratio above the median. So they are trying to find a subphenotype. This suggests that a subset of patients might have angiotensin II deficiency, which contributes to their shock state and could benefit from the Ang2 supplementation. Now, regarding plasma renin concentration study, patients with PRC above the median who received angiotensin II showed a significant likelihood of decrease in the plasma renin concentration. There is also note that increase in the survival rates of these patients indicate a beneficial effect of angiotensin II in patients with elevated plasma renin. So this is another group where we can use the angiotensin II. Now, implication in clinical practice is that these findings suggest a significant heterogeneity in the RAS system endotypes among patients with the vasodilatory shock. Now, based on the current evidence, it appears reasonable to use angiotensin II as a rescue vasopressor in vasodilatory shock as approved by both FDA and the European Association. The evidence specifically points to potential benefits in patients with elevated plasma renin concentration, indicating that these subgroup might derive the most benefit from angiotensin II therapy. Now, what are the knowns till now? What is known is its efficacy in the refractory vasodilatory shock. Angiotensin II has demonstrated effectiveness as a vasopressor in patients with catecholamine refractory vasodilatory shock, improving the MAP and survival rates. The other thing that is known is potential benefit in certain subgroups, as we have already described. So what are the unknowns? The unknowns is the broad patient selection criteria. Beyond the refractory vasodilatory shock, the specific patient populations that could benefit the most from angiotensin II therapy remain all clear. Because till now, the study actually included all patients with vasodilatory shock. So we are still unclear as to which patient population can actually benefit. Now, renin guided selection, while retrospective data using renin levels to guide patient selection has been shown in some cases, but it needs confirmation in prospective trials. Efficacy in stage 3 AKI. The potential preferential benefit of angiotensin II in patients with stage 3 AKI is supported by retrospective evidence but requires confirmation again in an AKI focused RCT. Primary and secondary vasopressor uses. The safety and efficacy of using angiotensin II as either a primary or secondary vasopressor across different types of vasoplagia need further investigation. Now, the influence of recent exposure to RAS2 inhibitors or effectiveness of angiotensin II therapy suggests an important interaction but requires elucidation in larger prospective studies. Now, the non-canonical angiotensin II pathways, the role of the non-canonical counter-regulatory systems in the vasodilatory shock and their interaction with the angiotensin II therapy is largely unexplored. I will explain this in details in the next slide. Uh, Coming to the future directions, prospective study of the renin-guided therapy, initiating studies to confirm the role of renin levels in optimizing patient selection for angiotensin II therapies are underway. Again, the AKI-focused RCTs are also to be done. Vasopressor hierarchy and the combination, exploring the position of angiotensin II in the vasopressor hierarchy and its combination with other agents through diverse clinical trials need to be done. Now, obviously, we also need to investigate the effect of RAS inhibitors, which is very commonly used nowadays for the hypertension treatment, on the impact of angiotensin therapy later on when they get admitted to the ICU with vasodilatory shock. And obviously, as I have told, I will describe in detail the non-canonical pathway. So this diagram basically summarizes the RAS pathway. Angiotensin, as you can see here, is produced from the liver. Then in the renin from the kidney converts the angiotensin to angiotensin 1. Now this angiotensin 1 is converted into angiotensin 2 by the endothelium of the lungs. What happens in sepsis or vasodilatory shock is that there is an endothelial injury. This endothelial injury inhibits the production of ACE, thereby reducing the levels of angiotensin 2. So, apart from the reduced availability of angiotensin 2 to produce the vasoconstriction, the sepsis directly inhibits the AT1R receptor. So, by inhibiting the angiotensin receptor 1, sepsis directly inhibits the action of the available angiotensin also. So, there are 2 points where the sepsis or the vasodilatory shock is working. First is by reducing the ACE level, the second is by reducing the AT1R receptors. So, what this does is this results in what is called as the vasodilatory shock. This pathway that I have described till now is called the canonical or the regulatory pathway. And there is a counter regulatory pathway, which is this side, which I will explain now. So what happens is once we give the angiotensin 2, the angiotensin 2 will directly act on the receptors and produce the vasoconstriction, thereby bypassing the need of ACE, and also because its concentration is increased, it is able to overcome the inhibition that is produced by sepsis in the AT1R receptor. Now, if we look at the other angiotensins that are produced, angiotensin 1 produces angiotensin 1 through 9, and angiotensin 2 here produces what is called angiotensin 1 through 7. And this angiotensin 1 through 7 produces two angiotensins, that is angiotensin 3 through 7 and angiotensin 4. All these angiotensins, which are produced by various peptidases, act on these receptors, that is AT4R, AT2R, and the MAS receptor. So these three receptors are the major receptors that are acting over here. Major action of the 84 receptor is vasodilatation and anti-inflammatory, while the 82, it mainly promotes increased blood flow, improvement in the blood flow, that is vasodilatation, and similar anti-inflammatory pathway. The MAS receptor is mainly involved with the recovery and the anti-inflammation. Now, how do these receptors act or interact in presence of an exogenous angiotensin II is not something which we know till now. These systems can definitely have an impact which can be seen in some patient groups. So we need larger trials, and we need more trials with angiotensin II in vasodilatory shock to see how these non-canonical pathways interact and affect the management of sepsis. So this table basically summarizes till all the RCTs that have been done till now. The first study was done in 2014 by Chawla et al. In 20 patients, where they showed the use of angiotensin to decrease the noradrenaline dosage. The most important trial, that is Khanna et al. In NEJM 2017, that is the Ethos III, it again showed a similar decrease in norepinephrine and an improvement in the MAP in patients treated with angiotensin II. The next is in cardiac surgery by Coulson in Anesthesia 2022, where they used this in 60 patients, compared it with noradrenaline, and had equivalent hemodynamic effects. The next is the Shock 2023, is a before after vasodilatory hypotension in 120 patients, where they found similar hemodynamic effects of angiotensin II compared to norepinephrine and vasopressin. Thank you for your patience. I hope the video was helpful. Please like, share, and subscribe the video if you like it. Thank you.